This talk's going to be about the general evaluation of bleeding in early pregnancy, and we're also going to discuss the entity of threatened miscarriage. Now, anyone working in the hospital, particularly the emergency department or the primary care clinic, is going to know that this is a very common presentation to the emergency department. Alongside nausea and vomiting in pregnancy, this would be the other most common reason to come to the emergency department. It's important to understand the causes that we're trying to evaluate and, risk stratify for in these women. And you can consider both pregnancy-related causes and other causes. Now, really what we're talking about in terms of what's important here is whether or not the woman has a viable intrauterine pregnancy, as in a threatened miscarriage, has a failed intrauterine pregnancy, or what we often refer to as a miscarriage, and there's several subtypes. Importantly, an ectopic pregnancy, a molar pregnancy, which I haven't put on that list, or a pregnancy of unknown location. And all these things have their own associated videos on this site to look for more detail. It's true that in some cases it's not related to the pregnancy, and the woman may have a cervical lesion such as an infection or an ectropion, which occurs in pregnancy and commonly causes postcoital bleeding, or even a cervical cancer if they've never had pap smears and no one's ever done a speculum exam. But really, the causes that we focus on in these women fall in this category on the left here, and we'll speak more about those now. Now, it's important to remember that some of these patients can be very unwell. This can be a life-threatening presentation. Now, it is very, very rarely life-threatening, but we need to have an understanding of what to do in these more, time-critical situations. And the causes that lead to hemodynamic instability are really ectopic pregnancy and miscarriage. Now, ectopic pregnancy causes instability due to hypovolemia and bleeding from a ruptured tube or ruptured extrauterine pregnancy into the peritoneal cavity, and a miscarriage can have two mechanisms. You can have profound blood loss and therefore hypovolemia, but you can also have cervical shock, whereby an incomplete miscarriage and some products of conception distend the cervical canal and cause a significant vagal response. I've got a small algorithm here which I elaborate on in more detail in the PV bleeding plus shock in early pregnancy video, but really it just allows us to utilise bedside ultrasound to make a rapid decision in these patients, because really where these women are at most risk is when they, for example, leave the department to have a formal ultrasound off in the radiology department, which is really a very dangerous and bad move. The algorithm really is that, of course, in the context of a resuscitation and rapid assessment, a fast scan can be used to identify whether there's free fluid in the peritoneal cavity or not. And as you can see demonstrated on the picture on the left, if there is, then it's likely to be ectopic pregnancy. The priorities here are to resuscitate with early use of blood products and or a massive transfusion, and organise the operating theatre for a salpingectomy. A lot of the other forms of assessment and management really are very peripheral, and these are the two time-critical interventions. If you don't notice that there's intra-abdominal free fluid, then it's likely the woman has an incomplete miscarriage with ongoing bleeding and or cervical shock. And in these cases, you need to do an immediate speculum exam to assess for and or treat cervical shock, which is done by using sponge forceps to either wipe away the products at the cervix or grasp the products and remove them. The second thing to do is resuscitate them with, again, early use of blood products and or massive transfusion. And you can even consider a uterotonic agents such as 250 micrograms of intravenous ergometrin or 1,000 micrograms of rectal misoprostol. And these women also should go to the operating theatre, but in this case for a suction evacuation. Now, the far more common occurrence is that these women are stable. And in this case, we revert back to our process of taking a history, doing examination, which includes vital signs, an abdominal examination looking for unilateral tenderness or significant pain in the midline, and then a speculum and vaginal examination. And the changes that we're really looking for here is if there's an opening of the cervix or if there's bleeding or purulent discharge, if on digital palpation there's cervical excitation, if there's an evidence for adnexal masses or tenderness, and it allows us to remove cervical products if present and or take a high vaginal swab whilst we're there. The role of the speculum and or PV exam is, I guess, controversial in these women. That the yield, the likelihood that you're going to find something that is not detected on ultrasound is probably low. So there's a trend away from doing these examinations routinely. But I think in women who have significant pain or suggestion of infection, or if you don't have access to ultrasound and you're considering discharging the woman, then some of these findings can help, I guess, clinically risk stratify these women into those that are suitable for an outpatient follow-up versus might need inpatient investigation. The standard investigations we do for these women include bloods for a hemoglobin level, a group and hold, both for consideration of blood transfusion if necessary and detection of rhesus status, and a beta HCG level. And these women will get a pelvic ultrasound, with a rule of thumb being if you can diagnose the pregnancy and get all the information you need transabdominally, that's acceptable, but a transvaginal scan is the gold standard. And the goals of this are to locate the pregnancy and assess whether or not it's viable. Thought I'd touch on beta HCG just briefly. It really has several roles, and that is to diagnose or exclude pregnancy. The concept of the discriminatory zone is useful. So it was initially around diagnosing ectopic pregnancy, but the evidence around that use is pretty mixed and inconsistent. Really now the idea of the discriminatory zone is that with a transvaginal scan, a beta HCG level over 1500, you should be able to see an intrauterine pregnancy if it's there. And the corresponding level for a transabdominal ultrasound is 6000. And I think that can just help you as a clinician understand what you might expect to find, counsel the woman, and therefore interpret the results. I don't think it can be as strongly correlated with likelihood of ectopic pregnancy, although as the beta HCG gets higher, if a intrauterine pregnancy isn't present, the likelihood of ectopic, of course, increases. Beta HCG can be done serially to help further aid in the diagnosis of a pregnancy of unknown location, and there's a separate video going into much more detail there. And also to follow up the beta HCG level to 0 following a failed pregnancy or in the setting of gestational trophoblastic disease. Now, I mentioned these 4 features because in my mind clinically that is the utility of the beta HCG. These women often get ultrasounds, and once you have an ultrasound showing a viable or non-viable pregnancy, the beta HCG level doesn't offer any more diagnostic assistance in that. Really the way to further evaluate the women if they have more symptoms is to get another ultrasound. Now I want to talk briefly about threatened miscarriage. And anyone working again in primary care or the emergency department will realise this is probably the most common cause of early pregnancy bleeding. Now simply it's defined as symptoms of a miscarriage but a viable intrauterine pregnancy. And one of the most enjoyable utilities of point of care ultrasound is the evaluation of early pregnancy bleeding. And a viable intrauterine pregnancy is very reliably, easily and rapidly diagnosed using point of care ultrasound. And there's been numerous studies involving emergency clinicians, both consultant level, registrar level, where the utility and accuracy of this modality has been upheld. The difficult thing with threatened miscarriage is quantifying the ongoing risk to the pregnancy, and the studies on this probably haven't been able to give us a clear incidence, and the subsequent miscarriage rate is probably somewhere between 10 to 20 or 10 to 25%. The difficulty around this also is we don't have any clear evidence of something we can do to mitigate this risk further. And that can mean that women might leave our care wondering and feeling a little bit helpless into how this can be managed moving forward. But I guess this is probably best dealt with by just clear, polite communication and giving them a good understanding. And I guess focusing on the fact that their concern of a miscarriage when they came to the department has been, it's, I guess, a really positive thing that the baby is still doing okay. Now, I wanted to talk briefly about the use of oral progestogen. Progestogen is a synthetic form of the female hormone progesterone. And as we know from, I guess, maternal physiology, progesterone is secreted by the corpus luteum in the first part of pregnancy and helps support the pregnancy until the placenta develops around sort of week 10 and onwards. There's been some research into the role of progestogen in reducing the miscarriage rate following a threatened miscarriage. And there's a Cochrane review done in 2017 which did a meta-analysis on 7 placebo-controlled trials with just under 700 patients. The results were encouraging in that for oral progestogen, they found a risk ratio of 0.57 with a 95% confidence interval that stayed on the side of benefit to the intervention, which means the confidence interval didn't cross 1.0. However, its effect on later pregnancy outcomes wasn't as clear, and the role of vaginal progestogens didn't suggest any benefit. But for the moment, I guess there's a potential benefit there for oral progestogens, although it hasn't yet become part of routine practice, although I feel that we're going to see more research and hear more about the role of progestogen in the future. Now, subchorionic hematoma. This is something that is commonly seen on ultrasound reports and is frequently an area of confusion, and I guess rightfully so. The studies around its importance are quite mixed in their findings, and however, it is also something that is a very concerning thing for a woman to read on an ultrasound report. So therefore, I think it's really important we have an organised approach to discussing subchorionic hematoma. Now, what it is it's a perigestational hemorrhage where some blood or fluid collects between the uterine wall and the chorionic membrane. And then it becomes a common cause of ongoing first and even second trimester bleeding. The effects on pregnancy is that it does have an increase in early pregnancy loss. There's been a lot of observational studies on this, and the findings have been a little bit mixed, but I think it's probably fair to say there is an increased in early pregnancy loss, although again quantifying that is difficult, and also intervening on that at the moment there are no proven methods. And as I was saying, the evidence is a little bit inconsistent regards to how high the risk is of ongoing miscarriage, but also the effect of the size of the subchorionic hematoma. Now, it makes sense that a larger subchorionic hematoma might exert more pressure on the pregnancy or have more separation of what will subsequently be the placenta, and therefore might carry a higher risk of miscarriage. But it is a little bit unclear at the moment as to the exact effect of the size on the risk. Now, there's been numerous complications studied in later pregnancy. The literature that is around suggests that there probably is an increase in the risk of placental abruption later in pregnancy, but the associations with preeclampsia and small for gestational age and threatened or true preterm labour, I should say, really aren't as consistent. So at the moment, the take-home points, I guess, are that subchorionic hematoma is a common finding with threatened miscarriage. It probably does increase the risk of early pregnancy loss and later on in pregnancy of placental abruption. But I guess we're not sure some of the specifics around those risks, and also the other associations with pregnancy complications aren't clear. This is an example of a subchorionic hematoma just next to a gestational sac and fetal pole. And it's worthwhile taking the time to have a look at ultrasound images of your patients, but also then having the conversation with women so that you're the first person to address these concerns before they go home and inevitably do their own research online. So that brings to an end the discussion around bleeding in early pregnancy evaluation and threatened miscarriage. I hope that was helpful, and if you're prepping for exams and want more free practice, jump onto freeobstetricexam.com. And if you'd like a deeper, structured approach to learning obstetrics, the kind that actually sticks, check out theobstetriccourse.com anytime.